located in Asia and Oceania. Good afternoon, people in Europe, and good morning for those who are in the Americas. The topic of our lecture today is very clinical. The title is Some Misinterpreted Lesions in the Oral Structures, and our lecturer today is Dr. Johann Beck-Mannagetta. He is from Austria. He graduated in medicine in the University of Vienna and in dentistry in the University of Graz. He was consultant at the University Clinic of Oral Maxillofacial Surgery of the Paracelsus Medical University in Salzburg, and he was also professor in the same university. This is a very, very clinical presentation, and I'm sure we are going to enjoy very much the presentation. Thank you very much, Professor Beck, for accepting the invitation for these webinars. I know it's a challenge for you because it's your first presentation through the internet, so thank you very much. And you can proceed with your presentation. We remind our audience that after this presentation we will have a time for questions round, and you can send your questions to our speaker by using the chat window of the software of the webinar. Thank you, Johann, and you can proceed.
Thank you, Professor Hueto. I'm very glad to have been invited to give this webinar. I have thought about the topic, and I found that misinterpretations always happen and you never know when and why. So I think it's important not only for the patient but also for the treating physician, and of course also for the families of these patients. I have selected a number of cases that you may find interested, but maybe some are very clear-cut cases, others are more tricky and difficult. Misinterpretations can arise due to insufficient history taking of the patient, to a clinical judgment that was an error, to a judgment by the histopathologist that was not correct, to insufficient tissue or cell sampling by biopsy or fine needle aspiration, but most important and very frequent, it is insufficient communication between the clinician and the pathologist. This pathologist has necessarily get to as much information as possible. So it is no use not to give the pathologist the X-ray, for instance. This may lead to over or underdiagnosis of a lesion, and it means harm to the patient and their families, especially if children are involved. Now, let me start with some tissue lesions. This is a child with aphthostomatitis. Aphthostomatitis usually occurs in a mucosal area that is not covering bone. This is in contrast to secondary herpes, which usually will manifest itself on the gingiva or the hard palate. This is important because the therapy is quite different. For aphthostomatitis, you can use Orabase, lidocaine, and similar products, but this should definitely not be used in case of secondary herpes. Now, we come to the so-called potentially malignant disorders. This is a rather new term, and it replaces the term of precancerous conditions, etc. Also, among this category, you have the speckled leukoplakia, erythroleukoplakia, and similar lesions. Leukoplakia in general is a clinical term and should not really be used by the histopathologist. These lesions have a higher likelihood to develop into squamous cell carcinoma than the normal mucosa. They should be taken seriously. They should be documented and verified by histopathology. and the patient should be asked for risk factors and advised accordingly. Once malignancy has been ruled out, the patient should still be followed closely, because sometimes one may overlook something and the patient will have to pay for that. This is a case with different areas of leukoplakia. There is one area with very slight hyperkeratosis, one with thick hyperkeratosis, and on the lower left, on the underside of the tongue, there is a more reddish area. The problem is that you can document this by taking photographs, but you should never forget to palpate these lesions also. And if you palpate the lesion on the lower left, you will find that it's indurated. So, and this is very suspicious for being a precancerous or even cancerous area. The difficulty, especially for the practicing dentists, but also for the maxillofacial surgeon, are the small carcinomas. They are, in this way, they are a challenge because they may be mistaken for some trauma. Here it was an incipient squamous cell carcinoma detected incidentally during oral hygiene. This is another one, an area in the orifice of Wharton's duct on the right side, an early squamous cell carcinoma. It is very important to recognize these lesions as early as possible, because then the future of these patients are much better. The prognosis is greatly improved and much less surgery or other interventions are necessary. And it can be difficult. Let's see at this case where you have also a rather extensive leukoplakia in the floor of the mouth. And if you look closely towards the teeth, you find that there is already an exulceration. And so it's invasive cancer, and it was operated as necessary. Another case where a cancer and dysplasia developed under a very extensive bridge. It looks like it could be mistaken for a periodontal disease, but if you look at the other side, it's already quite widespread and probably well differentiated. Still, it needed a large resection and reconstruction. So it's very important to watch these patients very carefully and, of course, ask for risk factors. A potentially malignant disorder is erosive lichen planus. Here you have a patient with the lichen planus hyperkeratosis in the right cheek, and in one of the areas you find a red lesion which is indurated, and this was already early squamous cell carcinoma. So if you have a patient with erosive lichen planus, you have to follow him or her as long as possible and make him aware of the danger of malignancy. This happening, that erosive lichen planus may develop into squamous cell carcinoma, is important, especially if you find an induration surrounded by lichen planus. You have to verify this area by histopathology, and you always have to check the nodal status, so the cervical lymph nodes, and make a photo documentation. It can, so far, it can be tricky because the patient may have a history of trauma or is a chronic cheek biter, etc. Then it can really be difficult, but it's in the best interest of the patient to rule out malignancy or to prove it as soon as possible. Now this is an easy one for a change, median rhomboid glossitis, mostly due to hypertrophy in the middle of the tongue, of the dorsum of the tongue, probably caused by excessive inflammation due to candidiasis and bacteria. It will go away once the infection is treated, and so actually there is no need to operate. Apart from that, it's very rare that a cancer develops exactly in the midline. This would be an extreme exception, but of course anything can happen, so you really have to be careful not to overlook it. Another difficult lesion is what is called the proliferative verrucous leukoplakia, or PVL. This was a 70-year-old patient with PVL who had gone to various clinics all over Germany and Austria and did not want to have this lesion removed. So all histopathologic investigations were negative for cancer. They only showed slight or moderate dysplasia. And this is what is so difficult to evaluate this lesion. After 8 years of observation, he developed this highly differentiated squamous cell carcinoma at the very back of his mandible. So it was a small operation, and he went well later. But in the end, we really had to resect all this gingiva and the underlying bone, and also sacrifice the teeth. But about a year later, a similar lesion developed on the opposite side of the mandible. So it's really hard to make a prognosis how these lesions will behave in the course of the year. One can say that they are slowly and gradually developing, but they more or less will progress to cancer. It only depends on after how many years. This PVL has as a leading diagnostic feature an extensive hyperkeratosis, which will develop into squamous cell cancer over many years. Histopathology, as I said, can be misleading because usually they only exhibit slight or moderate atypia. It is an obligatory precancerous condition. You should make a photo documentation, and you should make a lifelong follow-up. Now let me show you some melanotic or dark lesions. The significant to diagnose these lesions is that they may really, in reality, be a mucosal malignant melanoma. And this can be a deadly diagnosis, as you know. Let's start with this superficial spreading melanoma. This was first noticed by the dentist, and he recommended to have a biopsy taken, but the patient refused the biopsy for more than 5 years. After that, he came to us where we took this picture, and it was already invading into bone. The maxilla, part of the maxilla had to be resected, but later on the patient still developed metastases in the lungs. So it would have been much better if he had obeyed his dentist's recommendation. Now this is fortunately a harmless lesion on the hard palate, a so-called melanocytic nevus. No need to really to resect anything, but it should be a biopsy should be taken just to rule out melanoma. A rather rare condition is the Logier-Hunziker syndrome, where you have excessive melanin production in the basal cells of the gingiva. As I said, this is harmless, but still should not be mixed up with a melanoma. Here you have an amalgam tattoo of the cheek due to some metallic rests from restorations that should usually be in or near the gingival crest, but here it was in the cheek. In the histopathology, you find these metal oxides in the tissue, not only as large areas, but also in tiny bits in the lymphatic vessels. Another example of a discoloration in a young patient after a cystectomy and epicoectomy with dental filling. Here you have the corroded dental filling, endodontic filling, which gave rise to this dark discoloration. Now, in general, we should just make a few remarks on the biopsy and the biopsy report. Usually it's a very definitive diagnosis, either benign or malignant. Sometimes you have an ambiguous report, which brings you to the question, should we biopsy again, or should we ask for a second opinion, and these things. I think in the interest of the patient, one should not refrain too harsh from a re-biopsy or from a second opinion. Very infrequently, useless material is sent to the histopathologist, like necrotic tissue or blood or pus. This happens more often in fine needle aspiration technologies. Now let's come to the bony or osseous lesions in the jaws. This was suspected to be a cyst, an incisive canal cyst, but it turned out to be just a wide incisive fossa simulating a nasopalatine or incisive canal cyst. As you know, the nasopalatine ducts and also the vessels and nerves are bilateral, and they can be quite some distance apart, and they may simulate a nasopalatine cyst. So nowadays, with the advent of cone beam CT, it is not difficult to make the diagnosis. But in former times, one would have to make a probatory needling of this area and find that there is no cavity, no bone cavity, so a cyst could be ruled out. Another area of misinterpretation could arise after a cystectomy. Here it was a non-vital lateral incisor next to an endodontic filled incisor, and it was taken out. It was a through and through defect, bony defect of the anterior maxilla, and so after the root resection and new filling, it looked like this. So the whole area was more radiolucent than before. About 8 or 12 months later, the patient complained of some sensations, not really pain, but funny sensations. So another radiograph was taken, and here you see still quite some radiolucent area where formerly the cyst had been. So the surgeon suspected a recurrent cyst and made again what he thought to be a cystectomy, and when he sent them, he found no cavity and sent the tissue to the pathologist. The pathologist only found scar tissue and no sign of a recurrent cyst. This happens not so infrequently if there is a full thickness defect in the anterior maxilla, because probably of the damage done to the periosteum, bone cannot really regenerate very well. So there is always the possibility of just to treat a scar lesion. The patient should be informed about this possibility and not always immediately undergo surgery. Again, cone beam CT can exclude such a case. This is probably an easy one for all of you. Stiffness, latent lingual bone cavity, usually below, situated below the mandibular canal. It's not really a cyst, it's just a lingual defect of the cortical bone, not to be mixed up with a true cyst. This is quite an extensive solitary bone cyst in the mandible of a young patient. From one second premolar to the other second premolar. All teeth are vital and not damaged in any way. This was a chance finding just before going into orthopedics. So these cysts should be opened, and here we have the open pseudocyst, which is not lined by epithelium. You just have to let it bleed and fill with new blood, and then it will heal without any signs of recurrence. But it's important to know this possibility. Another easy one, mandibular tori on the left side. Nobody knows why these exostoses really come into existence. We can only speculate. The patient is never really aware of these lesions, and they only can make problems if a denture will be placed on them, because then you may end up with some traumatic ulcers. So they should only be removed if they really are disturbing. But if they are removed, be careful to keep the patient in follow-up, because these lesions are well vascularized, and if a hematoma of the floor of the mouth develops, it can be a deadly situation where the tongue goes up to the palate, and these patients cannot even be easily intubated by the anesthesiologist. The basal cell nevus syndrome is known for the multiple keratocysts in the upper and lower jaw. The new WHO terminology of 2017 says that the odontogenic keratocist is not a tumor. So the former term of odontogenic, keratinizing odontogenic tumor is not anymore applicable. We have in this case, I only did cystostomies, so I just opened the cavities and made some I made some packing of these cavities here in the upper jaw and in the lower jaw, and they developed quite nicely, and the orthodontist was later on able to make a good alignment of these displaced tooth germs. Here you have the almost final X-ray of this patient, but of course you can never be sure that not more cysts may develop later on, but I don't think it's justified to call them recurrences. They are new formation of cysts according to this syndrome. So this syndrome, which was first described by Golin and Goltz, is autosomal dominant trait, and it is characterized by multiple basal cell carcinomas, multiple keratocysts in the jaws, malformations of the vertebrae and ribs, and also intracranial calcifications. But as I said, these cysts are just cysts and not a tumor. Now we come to another area of possible misinterpretation. It is the periapical cemento-osseous dysplasia. This was a young person. You have vital front teeth in the lower jaw, but they have periapical radiolucencies though. So these were mistaken to be inflammatory tissue, and some courageous, go back. And we did a CT scan where you also see these radiolucencies in the mandible. And also on the other, in another projection, you see almost through and through cavities, radiolucencies, and some courageous experts did apicoectomies and root filling in all these 4 teeth that had been vital and stable and wonderful before. So this is what I call a definitive misinterpretation that actually should not really happen. The histopathology of these lesions is very similar to fibrous dysplasia, especially if you don't give the pathologist any hint about the radiology. So it was originally mistaken to be fibrous dysplasia. According to the WHO 2017, cemento-osseous dysplasias are ill-defined non-neoplastic lesions located in the periapical region of 1 or more teeth. In the mixed state, a radiolucent halo usually separates this lesion from the surrounding bone and the root surface. And as I said, histopathology reveals features of cemento-osseous fibroma. But it is not a tumor, it is a malformation. Of course, there are radiological stages of this dysplasia. First, it starts as an ill-defined periapical osteolysis with the proliferation of the connective tissue surrounding the tooth apex, several small calcifications later on within the osteolytic area, and these calcifications will be surrounded by a halo, a radiolucent rim of connective tissue. But they are not inflammatory, they are not a tumor, they just should be observed, and that's about it. So what should we do? We take a history, we take a vitality test, take X-rays and maybe a cone beam CT, and we always have to rule out a parathyroid adenoma for a possible giant cell, central giant cell granuloma. Therapy consists of observation only, because we should never treat an X-ray image, we should treat patients and not X-rays. The diagnostic problems may arise in these cemento-osseous dysplasia if there are clinical symptoms like inflammation, periodontal disease, if some teeth are already non-vital, if the lesion is in its initial stage without any calcification, and errors can occur if we do an incisional biopsy of this lesion, if we do endodontics or even extractions. The inherent danger of an extraction can be a protracted wound healing, infection, sequestration. So we actually should be aware of this possibility and try to avoid it. Another bony lesion is the central giant cell granuloma. Usually it's a chance finding. We find sometimes swelling, pain, and even root resorption. Radiographically, it's a well-defined radiolucency without sclerosing margins. We find multinucleated giant cells in a vascularized stroma. These are in reality osteoclasts. Therapy should consist of thorough curettage, but we have always to be on the watch out for recurrence. And in case of a recurrence, various approaches have been recommended, like intralesional steroids, calcitonin subcutaneously, or interferon alpha-2. The differential diagnosis would be a giant cell tumor, which has never been observed in the jaws. a differential should be the brown tumor of hyperparathyroidism, or in children, cherubism. Here's such a case of a young boy with a rather extensive lesion, which could be a cyst. It was curated and recurred very rapidly after a few months again. Here we have already the recurrence, and so we curated again and used calcitonin nasal spray that was at that time available. Here you see the histology with some bone, with the osteoclasts, the giant cells, and also the cell-rich stroma. After the treatment, the bone and the alveolar crest developed normally, and by the help of a very good orthodontist, all teeth were aligned in the proper arch. So, and there is no more sign radiologically of the possibility that there once was a rather extensive giant cell granuloma. Just a few words on hyperparathyroidism. In hyperparathyroidism, which may also cause these giant cell granulomas, the calcium is elevated, phosphate is down, and parathyroid hormone is also elevated. As symptoms, we sometimes find kidney stones and calcifications in the bones. There can be the loss of the lamina dura. They have been called brown tumors, and multiple lesions are found in ostitis fibrosa cystica generosata Recklinghausen. Also, duodenal altos have been reported. Another case with a large, extensive, obvious cyst with displaced tooth germs. Here are the premolars. This is the canine, and already some root resorptions on the other teeth. Was signed out as amyloblastoma by the pathologist, and as it was appeared to be a cyst, I was very reluctant to do a resection in this child. So we only opened it, removed the deciduous teeth, and made an obturator after. So this is just the intraoperative view where you see this cyst. I suspect it to be a unicystic amyloblastoma, so we treated it very conservatively, and it was possible that these teeth came into almost their correct position. And when I wanted to publish this case, it was found that this, by a second opinion by various experts, to be not an amyloblastoma, but an adenomatoid odontogenic tumor, which is now being regarded as a very, very benign lesion, and some even claim that it's just a hamartoma and not a real tumor. So this was the alignment of these teeth, and here you have the full arch with a retainer, orthodontic retainer. There is no risk of a recurrence, and I'm very happy that, not knowing that I was doing the right thing, I did not treat an amyloblastoma, but an adenomatoid odontogenic tumor. This is the final X-ray of this lesion, and the final frontal view of this case. One last word to a salivary gland lesion. Here we have a necrotizing cyanometaplasia in a young woman. It was a painful lesion. All of a sudden, there was a swelling on the palate, and we did X-rays and even magnetic resonance, and of course a histopathology. And these lesions can easily be mistaken to be squamous cell carcinoma, but it is just a poor a poor vascularization of a salivary gland, which leads to this replacement epithelium, which resembles squamous cell epithelium. So it can easily be mistaken for a squamous cell carcinoma or for a leukoepidermoid carcinoma. This is the lesion about 6 weeks later, and it fills itself with granulation and scar tissue, not leaving much of a defect anymore. But it is very important, as you will see in the next picture. This was President of the United States, Grover Cleveland, who had a hemimaxillectomy in the June of 1893 due to an erroneous histopathology report. Unfortunately, the specimen was kept in a museum, and it was found that, and experts are still arguing whether it was a highly differentiated verrucous carcinoma or even this necrotizing xylometaplasia. So even if you are a president, you are not safe not to have to undergo erroneous treatments, diagnosis and treatments. How can we avoid misinterpretations? We should take really time to make a profound history. We should use our best clinical judgment and imaging techniques without excluding common sense, asking for risk factors, etc. The tissue sampling or cell sampling by biopsy should be done by a qualified person. So this is very important to select the right point for a biopsy. Also, the histopathologist should be well trained in maxillofacial pathology. And in case of difficulties, please always ask for a second opinion, especially if your patient is a child that is still growing. So I want to stress and emphasize the need for excellent communication between the clinician and the pathologist. Only then these, I don't want to call them mistakes, I want to call them misinterpretations, should be avoided. Here we have two colleagues and partners with the same task of pulling a carriage, but they don't communicate with each other. Now I want to thank you for giving me your attention and time, and don't forget, first think and then act. Thank you very much. This is just a list of references which I will leave later on for you to copy. And now I want to thank you and start the discussion.
Thank you very much, Professor Beck, for this useful and extensive review of these lesions, some of them very frequent in clinic for maxillofacial surgeons, some others not that frequent. And now we will have time for a few questions. I remind you that you can address your questions and comments to our speaker by using the chat tool, and I will collect these questions and address that to Professor Beck. I would like to open this question round focused on the radicular cysts. Radicular cysts are very frequent in clinic, and do you think it's always necessary to submit a specimen of this cystopathology in all cases?
I don't think it is necessary to submit a specimen of usual periapical granuloma to the histopathologist if it's a clear-cut case. If you have a non-vital tooth, then and there's also the clinical picture, the clinical image and impression that it is just a granuloma. But if it is larger, larger than, and if it extends beyond this tooth, so if 2 or 3 teeth are involved, I certainly recommend to send it to the histopathologist, not for a single tooth.
And another very tricky condition is are oral lesions in pregnancy. I've seen some lesions that sometimes are very difficult to manage, and during the pregnancy. What are the most important lesions we can see during the pregnancy, and what is the management of that?
Well, the best known lesion in pregnancy is, of course, the giant cell lesion, the lesion that is due to the different hormone status of the woman that is reflected in the gingiva. But these lesions, they tend to bleed, and if they're really very annoying, they should be taken away. But the patient needs to be informed that these lesions may occur as long as she is pregnant. After pregnancy, these lesions will subside and go away. Other lesions, I'm not so sure that they are so frequent. Of course, after in any risk, any stress situation, oral apathy may occur, but there should be no problem. They need to be covered, and the patient should be assured that it will go away in about a week. Pain medication, of course, in the first 3 months during pregnancy are not so good, but later on I think one may definitely be able to prescribe pain medication, but better are, of course, local therapies. Okay. Does this answer your question?
Yes, thank you very much. We have a lot of questions coming from our audience, especially those related to the giant cell tumors, especially regarding the treatment of these lesions, the alternatives to the surgical treatment. What can you explain a little bit more about the recommended treatment for these giant cell tumors, the use of intralesional corticoids, the spray of calcitonin, etc.?
Yeah, there have been quite large studies by a Dutch group of maxillofacial surgeons, and they have very good. They were able to show very good results for giving calcitonin to the recurrent central giant cell granulomas. It did not work in every case. I think in a series of 20 cases, they had 1 failure. Nobody knows why. Other persons have good results, have shown good results with intralesional steroids. But all these approaches should only be done once the region is recurring. I think the first approach should be a careful curettage, but not too extensive, not to do harm to any displaced tooth germs, etc. But try to really to preserve the tooth germs, because it's so important for the child not to be mutilated at an early age. If the lesion really recurs, which is not always the case after the first curettage, some are just cured by 1 curettage, and then you have a good histopathology, and then if it really recurs, if it becomes quite aggressive, which we've seen such cases, then you should think about using a conservative approach, as I said, with intralesional steroids, with calcitonin, or with interferon alpha 2. I think it is what I wanted also to stress is be conservative as long as you treat a growing child, because mutilation in such an early age is terrible and never can be completely reverted.
We have a question coming from Glenda de Villa. Can you please explain more how the odontogenic keratocyst was classified as a keratinizing odontogenic tumor and now in 2017 back to a cyst?
I'm not in the board of the WHO collaborative field, and I never liked the term keratinizing odontogenic tumor, because you know, if you have treated a number of patients, let's say 15, 20 patients, if you have followed them, they are quite different. Some are very extensive keratocysts, others are very small, just around one tooth. And why should you resect make a continuity resection of the mandible just because one of these teeth has a keratocyst or a keratinizing odontogenic tumor? And I never had any problems with truly aggressive growth of these keratocysts. So between the WHO classification of 2005 and 2017, I probably did the right thing not to treat it as a tumor. But this is only my personal experience. And I think there are also other experts like Professor Scheer from South Africa. He also refused this term of the keratocyst to be a tumor. And I think we should be on the side of the patient. If something really recurs, and maybe in multiple areas, then resection might be considered. But usually these, especially in the basal cell nevus syndrome, they appear at early age, which means, again, possible mutilation of this child. And I don't think it is really justified if you are not, if you have not at least tried to be conservative.
There is a request from Ingvild Lane, if you can move back one slide to see the references again, if this is possible.
Oh. You mean this list of references?
The list of references, yes.
Yes, I'm sorry, I forgot about that.
Okay, thank you. Now the next question. What are the criteria for the enucleation of a lesion, or to do a biopsy first? The size of the lesion, the clinical appearance, the radiology?
I think the indication is not, usually it should not be difficult. If you can, by a simple procedure, if you can remove the lesion totally, and then you get at the same time, with one procedure you get the histopathology, and you have hopefully cured the patient. If the lesion is very extensive, and if you it is likely that you harm the patient by, let's say, removing or shelling out the entire lesion, then it is up to you to consider just an incisional biopsy and not to remove the whole lesion. I think this is something that really should be part of the training of an oromaxillofacial surgeon, to look for help in case where a biopsy is questionable. So more or less, the question is, as I understand it, do an excisional biopsy or incisional biopsy. And an excisional biopsy, I think, is justified in many cases where it is a small lesion without leaving any, without the risk of leaving something behind. But if it's not clear, such a clear thing, or if it's very extensive, then an incisional biopsy should be performed.
There is a question coming from a group of residents from Zaragoza, Mexico. What are the time and concentration of the gauzes in the surgical site after the enucleation of a keratocyst?
Excuse me, I did not get the beginning quite clearly.
Yes, what is how long do you leave these gauzes inside the cyst?
Yeah, I understand. Okay, the packing. I leave the gauzes for about 8 to 10 days. Then I take it out and do immediately an impression to make an obturator.
Mm-hmm. Another question coming from Indra Dewi Sutigno. Is there any relation between giant cell tumors and polycythemia vera, the blood disorder? Not
to my knowledge. Is there any coincidence with both lesions? I think they are completely different, and I want to stress that it is, at least in the jaws, there has not been a true case of a giant cell tumor. These were all giant cell granulomas, not tumors. So reactive.
Mm-hmm. There is another question about the giant cell granuloma coming from Altahib Mohammed. It is necessary to check the parathormone level in blood in cases of giant cell granuloma?
Yes, I think it is absolutely necessary, and it's really a mistake not to do it. Whenever you have a giant cell granuloma, you must check the calcium and the parathyroid hormone, because it may be a hint for a parathyroid adenoma. I'm sorry, I did not really stress that. Or even once we found, due to a parathyroid carcinoma, the giant cell lesion. So the giant cell lesion of the mandible was the first hint of a carcinoma of the parathyroid gland.
And another question coming from Omar Mohamed. What is the role of carnoid solution at present after the stigma of being carcinogenic?
I have not worked with carnoid solutions ever, and all I know from the literature, what I mean by common sense is, you never know how deep, how far carnoid solution, which is really very aggressive, will go into the bone or into the cyst lining. You may wait too long, you may wait too short. You can never be sure that only the cyst lining is really reached by carnoid solution. I think it's a very aggressive and dangerous approach, and I would not recommend it.
Okay, and now the final question coming from Diana Correa. How much oral manifestations does show lymphomas?
Oh, this is a very difficult question. I'm not aware of good statistics. Lymphomas, of course, can occur in the oral maxillofacial area, but it's rare, and it's especially rare if they are solitary and have no other manifestation in the whole body. So, but of course, they can happen. They can happen in bone. They can happen in soft tissue, and this is why the reason why we should recommend a biopsy in any swelling that has no clear origin.
Okay. So there are more questions from the audience, but we are running out of time. I would like to appreciate your presence here, Professor Beck. I think it's been a very interesting presentation and very useful, especially for young people, to know how to manage clinically these frequent conditions we see in our clinic. Thank you very much to our audience for being here, and we invite you for the next webinar that will be announced by the International Association of Oral Maxillofacial Surgeons. Thank you very much.
Thank you too.